So we've got this presentation that our medical student very nicely did. Would you like to repeat it? So it is a 63-year-old male transplant patient for a renal transplant. He's on R-CHOP for stage 3 large B-cell non-Hodgkin lymphoma. And he presented to the emergency department with a 3-day history of fever, worsening vesiculopustular eruption, and had pain and moderate pruritus with the lesions. He was treated with cefepime, vancomycin, and 2 doses of filgrastim. And by the next day, his fever had improved, but the vesiculopustular lesions had persisted and continued to spread. So this is his physical exam. You can see this disseminated vesiculopustular eruption. It was on his chest, axilla, shoulders, left and right arms, hands, and both lower extremities, face, abdomen, back, and feet. So basically his whole body. And what's really striking about this is this erythematous helo and this gray pustule. Gray pustules are generally bad news. Usually that means a lot of neutrophil activity, sometimes with an infectious cause. So here's a closer image of some of the vesiculopustules, and you can appreciate the dermoscopy here. So this is taken through a handheld dermatoscope. I'm holding one up in the video feed. It has a little light that turns on, and it has a magnifying lens that's polarized. That allows us to take close-up pictures like this, and here you can really appreciate that erythematous halo and that gray color. That gray color is usually, again, related to infection plus neutrophils. So our differential diagnosis included some reactive things like sweet syndrome, septic emboli, which was very high on our differential, septic vasculitis, disseminated fungal infection, leukocytoclastic vasculitis in the bullous form, and gonococcemia. As any dermatopathologist would do, I took a biopsy because the favorite whine of a dermatopathologist is more tissue, please. So we got a biopsy. We also did cultures. So I want to test your thought process about how you would manage this patient. With the information you have now, what would you do next? Intramuscular ceftriaxone, oral acyclovir, oral posaconazole, get a punch biopsy, prednisone, bacterial culture, DFA for HSV and VZV, or oral tecovirimat. So answer in your head. Of course, what we did was the punch biopsy as well as the bacterial culture. And this is the punch biopsy. So here you can appreciate that the epidermis is intact. So we have a vesiculopustule. Epidermal integrity is maintained across the breadth of the roof of the blister. You can see close here in the inset that we have numerous large colonies of bacterial cocci. Now this is what we see with septic emboli. So it kind of reminds me of those old horror movies. I'll show you in a minute. So histology was concerning for septic emboli. Blood cultures, however, had been negative. Echocardiography did not show any valvular anomalies, but the histopathology was really telling us that there was a hematogenous origin for these organisms. So it is that the call is coming from inside the house type of thing. And so when we interrogated the rest of the situation, we determined that it was likely the venous access port that was the source of contamination. And so that port was pulled and cultured. It came back positive for pan-sensitive MSSA, as did the lesion culture. And the patient had the device removed and started to improve. So here, clinical, pathologic, and microbial evidence pointed to a hematogenous origin for the infection. The venous access port was likely the site. He was started on nefcillin, and after the port was removed, he began to improve. When you're caring for patients who are immunosuppressed, you have to do clinical pathologic correlation, which means you take the information that you get from laboratory and pathologic diagnostic work, and you interpret that in the context of the patient. His history of lymphoma, treatment with immunosuppressive medications, and transplant status were all contributing factors. So how about our differentials here? So intramuscular ceftriaxone, we might use that for gonococcemia, oral acyclovir for zoster or herpes, possibly Coxsackie. Disseminated fungal infection, you might think about posaconazole. LCV maybe for prednisone, and you might even use tecovirimat if you thought you had monkeypox, or mpox, as it has been renamed, which is more appropriate. This was one of the chief elements in our differential diagnosis. Disseminated gonococcemia can look very similar to the presentation that this patient had. You can see that the patients get these vesiculopustules, and they can have that dusky erythema. This is a nice case from the literature showing cutaneous manifestations of disseminated gonococcemia, and again, you see that distressing gray color. A gray pustule is bad news. Usually it means a nasty infection. Now, this is the histology from that paper about a lesion of disseminated gonococcemia, and you're probably thinking you're seeing a little bit of deja vu here because this looks very similar. So over here on the left, we have the gonococcemia vesiculopustule. Over here on the right, the staphylococcal vesiculopustule. And this is the dermoscopy of those two lesions, that gray color surrounded by the erythematous halo. And here's the pathology. And the pathology is basically twinning here. So again, we see a vesiculopustule, the epidermis is intact. There are bacterial organisms at the base of the blister and a lot of inflammatory cells, predominantly neutrophils. This was also in our differential, so this is herpes. You can see the giant microbe of herpes here. This is eczema herpeticum, and this is a patient who's immunosuppressed that has these chronic punched out ulcerations of herpes. This is zoster, and here's a patient with impetiginized eczema related to stasis dermatitis that also has herpetic infestation. Disseminated varicella zoster could be a potential candidate for this patient. Usually you wouldn't see the pustules as widely spread as you saw in this case. And as you can see, the pustules for varicella zoster, because these are acantholytic pustules and you're more predominantly seeing the effect of the viral cytopathic effect, are more pustular appearing. So it's a yellow to white pus or a clear pustule or a clear vesicle, not that gray color that you saw. In histopathologic, we do see some of the signs of herpes, including multinucleation and margination of nuclear chromatin with molding of the nuclei. These are typical presentations of zoster in a dermatomal distribution, which can be hemorrhagic, especially in its early stages. And this is a side-by-side comparison of the embolic staph infection versus zoster. Zoster under the microscope has a lot of acantholysis. You can also see that there is inflammation, but not to the degree you see with a bacterial infection. And so the pustules have a more yellow color instead of that gray distressing color that you saw with the staphylococcal pustule. This is a dermoscopic image of a patient that has zoster. You can see that I'm using a glass slide here to provide a barrier between my dermatoscope and the patient's skin, which is useful for hygiene. These are cases of disseminated Coxsackie virus, which may occur in adult patients, and this can mimic a vesiculopustular eruption, but these are true vesicles. So you can see that they have a nice clear fluid within them. This is more commonly seen in children, but Coxsackie virus A6 can cause atypical presentations of hand, foot, and mouth disease in adults. This is the pathology for Coxsackie virus. So you can see it's mostly edema in the papillary dermis with an inflammatory infiltrate, but the destructive process of neutrophil degradation isn't happening. So you don't see that characteristic gray color you associate with septic emboli. And then fungal infection. Deep fungal infection is also in your differential when you have a disseminated eruption in an immunosuppressed patient. Typically, you're going to see more hemorrhagic, purpuric, or even eschlerotic lesions. So very common clinically with the disseminated fungal infestation, you will actually see black eschar-like membrane overlying a lesion of disseminated fungal infection. And leukocytoclastic vasculitis has many different presentations. This is the vesiculobullous type. So you can actually get blisters with leukocytoclastic vasculitis, which, as you know, can be caused by infections or medications and is fortunately typically self-limited. We see that relatively commonly in the dermatologic consultation service. It is also known as hypersensitivity vasculitis. It is the most common type of cutaneous vasculitis and is immune complex mediated. You have neutrophil-induced vascular damage, but no infectious disease. And so you have a different appearance of the vesicular pustular lesions. Epidemiologically, it's relatively common. 45 per million patients can express this finding. And usually you'll see it in patients that have other medical complexities. This is what it looks like under the dermatoscope. And here you can see clinical lesions on the ankles in this patient. We brought up tecovirimat, and I brought it up intentionally because this is an increasingly worrisome infectious disease. The first manifestations of this were almost exclusively in adult male patients who have sex with other adult males. However, the morphology and distribution of this disease is changing. So these are all lesions of Mpox. This is back when it was called monkeypox. And you can see that there is a lot of epidermal acanthosis associated with these lesions. So it's very keratotic appearing, very white looking, as many pox viruses are. So you can see here the viral cytopathic effect where the epidermis is thickened. We have a lot of inflammation, and you can appreciate that the lesions have a characteristic kind of whitish appearance. This is an orthopox virus. It was first kind of encountered in 2022 with community transmission. Incubation period is 5 to 21 days. You can see that we have definitely had cases of this virus in the United States. And we usually will diagnose this through a PCR from skin lesions sent to local or state public health lab or the CDC. You should report this if you find a patient you are concerned about. You need to practice good infection control with Mpox. So these patients need to be in a single patient room, disposable gown, gloves, and eye protection, hand hygiene, and an N95. Airborne transmission has not been documented, but we are using extreme caution with this virus. Cidofovir has been trialed. Post-exposure prophylaxis with smallpox vaccine and vaccinia immunoglobulin have also been reported helpful. Originally, patients almost uniformly had fever, headache, myalgias, and lymphadenopathy. The rash, of course, is the diagnostic finding, so present in 100% of patients, and you can see it progresses through stages, as do many pox viruses. They can have few lesions that can spread acrally into the body and usually last 2 to 4 weeks. It is, however, changing. So the prevalence of fever is decreasing, lymphadenopathy's prevalence is decreasing, and we're also seeing fewer of the other allied symptoms of myalgias, malaise, and headache. The demographics are also changing, and unfortunately, they're starting to target children in this virus. So in 2024 and into 2025, we're seeing more significant involvement of children under the age of 15 who are spreading this virus now through close contact and regular play. And 67% of cases and 83% of deaths in the 2024 outbreak actually occurred in children under the age of 15. So if you see acral vesiculopustular lesions or keratotic vesiculopustular lesions in children, this is something to consider. You can appreciate here in the New England Journal of Medicine, there was a small child that had this presentation that had Mpox. You can see this child is also heavily infested. Now, if we're going to talk about infectious diseases affecting children in West Texas in April of 2025, we've got to talk about, of course, measles. So we are in the middle of a measles outbreak here in Lubbock, Texas. The names we have for these viruses are maddeningly similar. Rubiola, of course, is ordinary measles. Rubella, German measles. They couldn't give them any distinction either way. I'm like, could you have named one of them slightly differently? And then Roseola infantum, which is a much milder version of any of these viral infections. But the one we're going to focus on here is rubiola, which is ordinary measles, presenting with those 3 C's, the coryza, cough, and conjunctivitis, remembering that the cough is a big problem because this is a highly contagious virus. It precedes the skin infection or the skin manifestations with the complex spots on the buccal mucosa, and the rash proceeds from the top of the body down the body. It is one of the most, if not the most, infectious microorganism in existence that we are aware of. If you have 10 people in a room and one of those people has measles, sorry, if you have 11 people in a room, one person has measles, 10 uninfected people, and that person is infectious, 9 of those 10 people will get measles. It's very, very highly infectious, and this is one of the reasons we're concerned about it. So if you compare it to other infectious diseases, and we talk about the R0, this is the basic reproduction number, the R0, how many people on average each infected person will in turn infect. And you can see for measles, it is the highest R0 and is highly infectious. Now, we are not unique in having a problem with measles, so I don't want to paint this as a United States issue. In Europe, there is a problem with measles as well. You can see here in these pie graphs, the darker portion is showing you adults who have measles, and the smaller portion is showing you, or the lighter red portion is showing you children who have measles, and the size of the circle is showing you how many patients. And so you can see there was a significant outbreak in Romania in 2017. There was a reasonable outbreak in other EU countries in 2019, and a lot of adults were infected. This is what the rash appears like. This is actually where we get the term morbilliform from. Morbilliform is like measles. And so a morbilliform eruption is like every drug eruption you've ever seen. Every regular drug rash you've ever seen looks a lot like measles. You can see these characteristic complex spots, these white punctate lesions on the oral mucosa. This is called an enanthem. So when you have a rash on the body, on the skin, it is an exanthem outside the body. When the rash is on a mucosal surface, it's an enanthem inside. Here's a child that has the conjunctivitis and the macular rash. Tearing is quite common in this setting. Here is another presentation of the complex spots. These little punctate white lesions, often described as grains of salt on a red background. And this is a child with skin of color. It is harder to perceive the erythema, but you can see here more clearly the papular nature of this eruption. So we talked about that R0 being very high, the incubation period 9 to 14 days, the prodrome where patients are heavily infectious and do not have the rash yet and do not know they have measles is 3 to 5 days. And during that period, they're exquisitely infectious. The side effects and the sequelae of this condition are serious, and about 30% of patients will have one or more complications, which can include ear infections, which can cause hearing loss. Patients can have eye disorders, destruction of the cornea, blindness. You can have patients that have severe diarrhea. Many patients will develop pneumonia. This is the most common reason for hospitalization and cause of death. You can have encephalitis in 1 in 1,000 patients, and in 1 in 25,000 patients, you can get something called subacute sclerosing panencephalitis, which is absolutely horrible. 1 in every 1,000 measles patients dies. We have had 500 cases in West Texas. We've had 2 deaths. We are actually exceeding the death threshold for these children. And the community is about 5,000 people. And to my understanding, the vast majority of those patients are not vaccinated. So the side effects and the sequelae can include pulmonary. You can have pneumonia, laryngotracheal bronchitis. You can have gastrointestinal symptoms with diarrhea, even hepatitis and lymphadenitis. Neurologic encephalitis, this acute disseminated encephalomyelitis, and then subacute sclerosing panencephalitis. Ocular findings including corneal ulceration and cardiac changes, including myocarditis and pericarditis. Subacute sclerosing panencephalitis is awful and is also a long-term risk. So all 500 of those children that have been documented to have measles now have this sort of Damocles dangling over their heads. So while it is rare, 1 in 25,000 patients, it can present with personality change, lethargy, behavioral changes, dementia, myoclonus, proceeding on to neurologic deterioration with autonomic dysfunction, and then finally a vegetative state. Not all cases will proceed through all portions of the disease, but it is a very severe condition and can present usually 6 to 8 years after the initial infection, but up to 27 years later. So it is the literal sword of Damocles over these kids. The best way to protect children and other patients from measles is vaccination. 2 vaccines given is the most protective way to manage, control, and prevent this disease. The WHO does recommend oral doses of either 200 or 100,000 international units of vitamin A per day for 2 days, only 2 days, for children with measles. Specifically, this has been shown beneficial in areas where vitamin A deficiency is present. We don't know how helpful this is in patient populations that do not have vitamin A deficiency. And it is meant to be given by healthcare providers at the time of diagnosis, not every day to decrease parental anxiety. You can also give measles immunoglobulin within 6 days of infection. Now, the problem is people with a large platform have touted the potential for vitamin A to prevent or treat measles. So that was March 5th. Here we have an article from March 26th. This is our Covenant Children's Hospital. And you can see that we are having patients admitted for vitamin A hepatotoxicity to the Children's Hospital because of intentional parental overdosing. Here is a CDC recommendation that came out 2 days after the statement was made by the current HHS leader about vitamin A, which says that vitamin A should be administered under the supervision of a healthcare provider. There are many different public awareness campaigns that have come up specifically about the fact that vitamins do not prevent measles. Giving high doses of vitamins, specifically vitamin A, may be dangerous, and the best way to prevent measles is through vaccination. So you can see that we are actually so famous now, we're hitting all the TikToks. So we have so many people doing TikToks about the fact that we are actually having children accidentally poisoned with vitamin A because people are trying to prevent them from getting measles in these vulnerable populations. Atypical measles can be a condition you might see. These are patients who were vaccinated with the killed measles virus vaccine between 1963 and 1967, who then are exposed to wild type measles. So these patients tend to be older patients, of course, because they were vaccinated at that time. They can present with a high fever, abdominal pain, pulmonary consolidation, and this acral eruption that is vesiculopustular and purpuric. So this is something to keep in mind for unusual presentations of what you think is leukocytoclastic vasculitis, especially for patients who would have been children in that time period. So the history of measles cases was a success story. We actually had this beautiful decrease in the number of cases after each iteration of the vaccine. 1963 dropped the rates significantly. They improved the vaccine in 1968. 1971, they put it together as the MMR vaccine. They started recommending the second dose in 1989 because there was a slight increase in cases and they realized a second vaccination would be helpful. And in 2000, measles was declared eliminated from the United States. However, this is what's happening this year. So we can see that we are leading the nation in measles cases. This is Texas. We have New Mexico in the green here. Kansas and Oklahoma are coming up underneath there, first and second. How do you diagnose this? You can do a serum measles IgM by immunoassay. It's detectable 3 days after the rash appears. It may be negative on the first day of rash. Molecular detection through RT-PCR specimens or urine for 3 days after rash onset. Differential diagnosis includes Kawasaki syndrome, scarlet fever, and rickettsial infections, as well as meningococcemia and other viral exanthems. And you must report measles if you diagnose it because it is so highly contagious. This is Kawasaki syndrome. You can see it shares a lot of features with measles. The things that can distinguish it are the prominent mucositis and acral changes, but these acral changes tend to happen later in the course of presentation. So really the oral presentation, the mucositis can help you. Lymphadenopathy is also a little bit more likely to be present in Kawasaki syndrome. So now we have case number 2. Thank you for letting me get on my soapbox about measles.
Alrighty, so our case number 2 is a 65-year-old man with a burning rash. He has a reported history of a skin condition which was previously under good control with acitretin and naltrexone, which he was still taking. The ER consulted due to the flare of this condition is pictured on the next slide. He related that the previous flares had been well controlled with prednisone, which he requested. He had been on trimethoprim sulfamethasone for the past 4 days.
So this poor fellow, when we went to see him in the emergency room, was in exquisite pain. He was actually shaking because he was in so much pain. So you can see he has these numerous eroded skin lesions. So if you were in my shoes when you saw this patient, what would you do? What would your next appropriate step in management do? And you can pick more than one answer. You can pick 2. Would you start prednisone as he's requested? Would you start doxycycline, check a DFA for herpes simplex, check a bacterial culture, do a PCR for MRSA, or start IVIG? Well, what we chose to do, because remember, I am a dermatologist who likes tissue and I like data. So we did a DFA for herpes simplex. We did a bacterial culture and a PCR for MRSA. So this patient had Haley-Hailey. It's a condition that's other name is benign familial pemphigus. I realize that does not look very benign. Pemphigus is a condition that's quite severe. There used to be a saying in dermatology that if you diagnosed a patient with pemphigus and they were not dead within a year, you got the diagnosis wrong. That was before we knew and understood to use immunosuppressants to treat this disease. So pemphigus, very serious. Haley-Hailey benign familial pemphigus does not kill people, but it significantly impacts quality of life. He was on the naltrexone and the acitretin to treat that condition. Now, herpetic eczema, eczema that gets infested with herpes, is a condition that patients with atopic dermatitis, Netherton syndrome, Haley-Hailey, and Derriers are at exquisite risk for because their skin barrier is not present. So the DFA for this patient was positive for HSV1 from the skin. He had MRSA that was Bactrim resistant, which is why he was not getting better. He had secondary infection with staph. And he has these punched out ulcers right here, very similar to the punched out ulcers I showed you in the earlier case. So if you see something that looks like somebody took a hole punch and made a little space in the skin, that's very typically going to be herpes, sharp margination and punched out ulcerations. This is a patient with skin of color with atopic dermatitis who had eczema herpeticum. I've shown this Kodachrome many times, and because this is a vesiculopustular eruption on a patient with skin of color, many people think this is smallpox. One of the other reasons I think people think this might be smallpox is that it's relatively monomorphic. So often when we see chickenpox, which is what we're used to seeing disseminated, it's in multiple different stages of evolution. Eczema herpeticum tends to be more coherent. So when you see eczema herpeticum, it tends to all be at the same stage versus chickenpox. And the reason kind of makes sense. When you're dealing with chickenpox, like an initial presentation, this is a systemic infection. When you're dealing with eczema herpeticum, this is a skin spreading infestation. And so it tends to be a little bit more monomorphic, which is why people tend to think that that Kodachrome is smallpox. Here you can appreciate these little vesiculopustules in this clustered array, and this is a very typical grouping for herpes. Who knows what herpes means? It actually comes from herpetiform. Herpes derives its name from a snake, and it's like thinking about a snake coiled up on itself, because that shape that a snake makes when it's coiled up on itself is reminiscent of how these blisters come together to make these little ulcerations like that. That's the patient after she was recovering. So we call this eczema herpeticum or Kaposi varicella eruption, and this is herpes getting into eczema or other skin conditions that break the barrier. This is the same patient after he recovered with appropriate treatment with antivirals and antimicrobials. You can see he has a lot of residual erythema that took time to resolve, where he had that intensive reaction to the herpes virus. So this skin is all intact and has normal sensation, but he has a lot of extra blood vessels that were built during the period of the acute eruption. We also sometimes use botulinum toxin to treat Haley-Hailey. So these are patients that have Haley-Hailey. This rash tends to present in the folds, arms, under the breast, in the groin. There is often a malodor associated with this because it grows bacteria very well, and that can make patients very self-conscious. We can treat this actually by decreasing sweating with botulinum toxin. So this is a patient over here that have been treating with botulinum toxin in the axilla. You can see where the disease is persistent at the edges where we didn't get enough Botox. So this is what you can see after you treat Haley-Hailey. And so that's that patient after he had the Botox treatment with the residual Haley-Hailey disease at the lower aspect. And now I have just a few quick quizzes to drive home some important points about infectious skin diseases we're seeing a little more frequently. So here we have a patient that has a generalized alopecia. You can see it's kind of affecting the entire scalp, and it's a little bit patchy. When we look up close, this is through the dermatoscope, what we can see is a lot of bent and broken hair shafts and scale. So when you're evaluating a patient like this, you might wonder, is this Ectothrix tinea capitis, Endothrix tinea capitis? So that means where the fungus is growing, and I'm going to show you what that means. Traction alopecia, so hair loss from wearing braids or heavy weaves or heavy, very high traction ponytails. Syphilitic alopecia or alopecia areata. So this is the clinical image. This is the close-up of this patient's scalp. And over here, this zigzaggy thing that was impossible to get in focus is one of these little bent hairs. So this patient actually has syphilitic alopecia. Syphilis is also making a comeback in our community, and so we do need to be aware of what it looks like. So when you see syphilis on the scalp, it does tend to cause the hair to grow irregularly, and you can actually get these bends and breaks in the hair shaft, and I like it when things make sense. So this is the hair shaft under the microscope, and that's what a treponeme looks like under scanning electron microscopy. So that will help you to remember that unusually bent and broken hairs may be attributable to syphilis, especially when there's the presence of scale. This is a patient that we saw at the free clinic. This young lady had been sex trafficked. She came for hair loss that had been attributed to stress. Looking close up at the scalp, we can see that she's got funny looking bent hairs. Under the microscope, it looked like this. This was, again, syphilitic alopecia. This is a patient with syphilitic alopecia. Again, you can see generalized alopecia and scale on the scalp. This is what it looks like up close. So scale is prominent in all of these photographs. You can also see that some of the hairs are bent or tapered. Tinea capitis, by distinction, can create patches of alopecia. When you look up close, you can see these comma-shaped hairs and scale. So scale is often associated with infectious alopecias. Culture takes time. It takes actually a month to culture fungus from the scalp, so trichoscopy can be helpful. This is what we call using the dermatoscope just on the scalp. That's trichoscopy. Comma hairs are present here. You can also get black dot tinea where the hair shafts are so fragile they break at the surface of the scalp. So this is that little girl's scalp that we showed earlier, and you can really appreciate how tortuous and destroyed these hair shafts are. They're very disrupted in their growth. It kind of reminds me of that TV series. Has anybody seen The Last of Us, where like the fungus zombies are walking around and they've got these things that come out of their mouths like, and it's like curly and it's looking for a next victim? This is what I think of when I see Endothrix tinea capitis. And so if you wet the scale, you can see even better how distorted these hair shafts are. And this is what they look like under the microscope. So these are hair shafts, and this is a stain for fungus. This is PAS, and you can see that the hair shaft is completely full of these fungal organisms growing all the way through the hair shaft. This is Endothrix tinea capitis. That's why it tends to twist and curve and break. So that's Endothrix tinea capitis creating all of this distortion. Ectothrix tinea capitis is more likely to cause a carry-on. That's what we call it when we get a big red angry swelling that's kind of like an allergic reaction to the fungal antigens. And you can see here the hair shafts have this gauzy stocking kind of pulled up the length of the hair shaft. So the hair shaft itself is intact, it's normal structurally, but it has a coating of fungus and a very significant inflammatory reaction in the background. This inflammatory reaction is so severe it often causes permanent alopecia. And when we start treating patients that have this presentation of Ectothrix tinea capitis, we actually, and this always feels wrong to do, give them prednisone together with their antifungal. Because when we start to kill the fungus releases antigens, and then the antigens tick off the immune system more, and you get more inflammation and more destruction of hair shafts. So you end up with more severe alopecia if you treat with isolated terbinafine versus terbinafine plus prednisone. It feels very wrong to give prednisone when you're treating a fungal infection, but in this particular case, it is correct. This is the microscopy of that case. So you can see these hair shafts decorated all over the outside with these very significant hyphae. Kind of reminds me of like Chewbacca's legs or something, just covered in these fungal hyphae. Here's another case of Ectothrix tinea capitis. Again, significant inflammation and that scale crawling up the hair shaft. Now back to my patient with syphilis. So this is my patient from the free clinic with syphilis. She had very few lesions on the palms, but they demonstrated this characteristic outward peeling scale, which we refer to as Biet's collarette. So this is the Biet's collarette, which you can see, and this is caused because of significant inflammation in the skin. These are other patients who also have secondary syphilis, and again, you can even without the dermatoscope, with your naked eye, you can see that collarette of scale. Now, that happens because of inflammation. Here's an article that we actually presented about this finding and from one of our patients that we took care of at the free clinic. Here's another good example, and again, notice the consistency of that outward peeling scale, that Biet's collarette. So there's a lot of variation what you see histopathologically with syphilis, but almost always the infiltrate is going to involve the epidermis because the treponemes are in there. So the reason we are cautious about contact, skin-to-skin contact with a patient that has secondary syphilis, is that their epidermis is literally teeming with treponemes. So if you stain for them, they are everywhere. You get a lot of inflammation, and you also can get epidermal acanthosis and a lot of what we call parakeratosis. So when we're dealing with a patient, oh, I can put it over there, that's nice. A patient who has syphilis, you can see acanthosis, so thickening of the epidermis, but it's this unusual acanthosis, these long, skinny, reedy ridges. One of my colleagues who teaches a lot about infectious disease and dermatology likes to say, okay, so you know it's syphilis because you've got these long, sexy, reedy ridges. And for some reason, that helps it stick in your mind. You can see very dense inflammation, and you can appreciate the parakeratosis, so abnormal stratum corneum that's very fragile and friable, which is why it peels outward. For any medical students watching who've learned about psoriasis and lichen planus, there are overlapping features of both of those conditions with secondary syphilis. And so I kind of like to think of the histology of secondary syphilis like lichen planus and psoriasis had a very messy baby. Lots of inflammation, lots of parakeratosis. And that is what creates, again, that characteristic scale. Here's another patient from the free clinic who had very bad secondary syphilis. Again, notice that collarette. I'm hammering this a lot because syphilis is also making a comeback. So this patient, I put in a lot of these pictures because I want you to just see many, many photos of that. You can see it went all the way down his legs. It was on the top of the legs, again with that characteristic scale, and all over the bottoms of the feet. We talk about copper pennies on the hands and feet. This patient was brought to the emergency room. He was relatively sick. He has posterior cervical lymphadenopathy, inguinal lymphadenopathy, and again, look at that characteristic scale. This is very severe secondary syphilis in the coexistence of HIV. So as a dermatologist, syphilis holds a special place in my heart because dermatology as a specialty exists partially because of syphilis. It was the disease to be mentioned in whispers only, but it helped us to establish our specialty because we were able to connect the findings on the skin to the internal disease and sort of wage the war against this disease, trying to deal with the conflicting interests of moral decency and public welfare, which unfortunately we still deal with these problems today. Who's had a patient that refuses to vaccinate their child for HPV? Right? Ridiculous, but it is a thing. It's a parental choice. I respect it, but it is something that I do wish we could treat medical conditions as medical conditions and moral conundrums. So we are seeing a resurgence of syphilis in the United States. Our previous modern day nadir was in 2001. And unfortunately, we are seeing significant increases in rates. So we were doing really well around here. Now we are seeing this upswing, and it just continues to go up. We think that a lot of this has to do with sort of hookup culture, a little bit of a loss of attention span. When we had HIV enter the scene, syphilis rates went down a lot because people were very worried about HIV, and they were doing appropriate safe sex protection activities. People have gotten more lackadaisical about that, and at the same time, we have technology facilitating lots of casual relationships. And so that combined with sex trafficking, which has become more prominent, is contributing to an epidemic of syphilis. So you do want to screen people at risk, asymptomatic non-pregnant adolescents and adults who've ever been sexually active. The benefit of screening outweighs the harms, and as dermatologists, we see this condition in patients you wouldn't expect it in a lot of the time. A few last challenge cases for you to highlight the pitfalls as well as the benefits of telemedicine. So this is a case from the COVID era. This was a 7-year-old girl. She had a telemedicine visit because of COVID-19, had a history of a recurrent itchy rash on her face, scalp, trunk, and legs and arms for 2 years. She tried hydrocortisone without relief. She was given triamcinolone over the teleinterface for the rash on her body and clobetasol solution for her scalp. In return visit, she has the findings I'm going to show you. So is this ectothrix tinea capitis, endothrix tinea capitis, traction alopecia, syphilitic alopecia, or alopecia areata? So you can see here she has a scaly rash on her face. And look at these hairs. Those are some cuckoo bananas hairs. You've got some very distorted hair shafts here and a lot of scale. So this was actually endothrix tinea capitis, like I showed you before, those twisted abnormal hair shafts that are caused by intense and significant invasion of the hair shaft by the fungal organisms. This is her hair mount, and you can actually see the fungal organisms just vomiting out of that hair shaft. They are so full that they're spilling out onto the slide. So this is what we would call tinea incognito. When tinea gets treated with steroids, it takes away some of the erythema and scale, and the fungus goes crazy. So these hair shafts were just full of fungus. So that was a good case to highlight one of the pitfalls of telemedicine. Now, this is a child that we saw very close in time to that other child. This child had a different finding, similar scaly rash on the face, some alopecia present as well. That child had lupus. So this is facial lupus. This is facial tinea incognito. The lupus over here with a little hair loss and scarring, and over here we have tinea incognito with those distorted hair shafts. This was a pandemic success. So this little girl is seen here after she had shots for intralesional Kenalog. So this was on her first follow-up visit. I did not take pictures during the telemedicine interface because we were in such crisis mode, taking pictures through the, did anybody do telemedicine during the COVID-19 pandemic? We spent a lot of time looking at people's ceiling fans and very out of focus, very dark images. Telemedicine can be used well, and we found new techniques to manage it, but at the time it wasn't very easy. So this was on her first presentation after telemedicine, but we'd already started her on some agents to manage her alopecia, and this was when we were seeing her in person and doing some injections, so that's why there's red dots on her scalp. This is her trichoscopy, little hair shafts just broken right off at the scalp surface, and tapered hair shafts, but no scale. So some overlapping findings with syphilis, but no scale. This is alopecia areata. This is that same patient after treatment that we were able to successfully start onboarding during the pandemic through telemedicine. So she was able to recover a full scalp of hair and start participating in social activities with her friends again. Thank you guys so much for your attention. I'm 2 minutes ahead of time for the questions. I'm very proud of myself for that. If anyone has any questions, please let me know. I will stay up here.
So just a comment, as somebody who grew up, I mean, I was born in 1953, and when I was growing up, everybody had measles. And yet, if you ask people what your biggest concerns were in the world, nobody would put measles in the top 100 or even 1,000. So the issue of measles seems to be a lot different in the cohort of people who don't see it as opposed to the cohort of people who lived with it. And I would think about that.
I understand. And, you know, for many people who have measles, it will be a self-limited infection, and it will be something that comes and goes without leaving significant sequela. But for that 30% that do experience lasting side effects, whether that is lung capacity limitation because of the pneumonia.
Somebody who grew up when everybody got measles, the incidence of serious sequela was less than 1 in 1,000. I mean, this is something I observed.
Well, and I think that lived experience is very important. The data that we have does show us that there are some significant risks, although many of them are quite rare. When we have something that is preventable through vaccine series that have demonstrated safety, and the side effect ratios of the vaccine series versus wild type infection, you really can't argue that the vaccine is more dangerous than the infection itself. Now, of course, anecdotal data is very persuasive. And if you have a person who knows somebody or is somebody who had a child affected by a vaccine side effect, those people are going to be very passionate about their viewpoint, which is completely understandable. You know, our lived experience as humans is always going to be very powerful in dictating our choices as well as our preferences. I think that I'm very sad for the 2 children that died. I think that how many children have been admitted to the hospital in Covenant? I feel like it was 100 at this point, but there have been many children hospitalized as well. And, you know, I do think that there is a rising distrust in vaccines that started to kind of take over after the badly written, now retracted paper about vaccines and autism was published. It also does show us the damage that bad science can do. We also saw that happen during the pandemic with hydroxychloroquine, with a study that wasn't well controlled and really wasn't a study that was ready for prime time. And I know that the people who published that study had the best intentions to try to get some information out there to help people who were treating an unknown viral pathogen that was very dangerous and complex. But there were a lot of people who ended up, you know, taking hydroxychloroquine that didn't need to. There were patients that needed hydroxychloroquine that couldn't get it. And at the end of the assessment, we were not really able to show benefit from that intervention. So it gives me consideration every time I publish something about the veracity of the information that we're putting forward. We always want to make sure that our data is well vetted, properly collected, and tries to represent the closest to the truth that we can get. That's the hard thing with science, is that we're trying to use our senses and our intellect to get as close to the truth of infinitesimally complicated microscopic organisms. You know, we can't approximate the knowledge of our higher power or of the universe or of the wisdom of evolution, or however you want to view it, because of the complexity of the organisms that we are and that we treat. But I think that our efforts to get closer to the truth, so long as they're approached with a sort of focus on bringing us as close to the truth as possible, are very important. Any other questions? Those were good ones. Do you have any questions on the Zoom? I don't know how to check that. Okay. Awesome sauce. Well, I am grateful for everybody's attention. I think that this has been a stimulating conversation. And if you have any questions or you have a presentation you're concerned, maybe one of the entities that we discussed today, all of you know how to get a hold of me through our Texas Tech emails. And I really appreciate the opportunity to teach and learn with you today.
Hello, everyone. Thank you for attending today's Project Echo Grands Round session. Just a reminder, please sign in on the paper in the front and complete the evaluation for CME credit, which will be due on Friday. I would also like to thank Dr. Michelle Tarbox, who is the Department Chair and Program Director for Dermatology, for educating us today. I would like to welcome Dr. George to present Dr. Tarbox with a challenge coin.
Thank you for the excellent lecture and the timely presentation of me. It's really helpful. Thank you.
Appreciate that. Thank you. That's really cool.
Thank you, Dr. Tarbox. And lastly, if you would like the lecture materials from today, please register on the iEcho website to access session materials. Thank you, and we look forward to seeing you at the next Project Echo session.